All right. So I am delighted to be here and thank you for this opportunity to speak about quality of life and acromegaly. The objectives for the next 25 minutes or so, I hope to describe the impairments in quality of life that are observed in people with acromegaly. We'll discuss the effects of biochemical control of acromegaly, which is defined in most of the research studies that I'll sort of present to you as a normal IGF-1 level on symptoms and health-related quality of life, and then describe the effects of radiation treatment, pharmacologic treatment, growth hormone deficiency, and time on quality of life. So I thought I'd start with this schematic, which I really like. It demonstrates the multitude and complexity of factors that may lead to a decreased quality of life in people with acromegaly. There certainly are physical symptoms, including pain, which can be distressing and debilitating and lead to impaired physical function and mental health. Some of the physical symptoms, as we've discussed, may improve, although others might persist, such as arthritis, or even progress despite biochemical control. Comorbid depression and anxiety are highly prevalent in acromegaly, and many patients experience poor body image and negative illness perception that detrimentally affect quality of life. And then finally, treatment modalities such as radiation treatment or the burden of being on chronic medications may impair quality of life, as well as some of the negative consequences of treatment like hypopituitarism. And we'll explore these factors kind of over the course of this presentation. So I just wanted to introduce the ACRO-QOL, which is the only validated research questionnaire that assesses quality of life in people with acromegaly. It is a 22-question self-administered survey that asks questions specific to acromegaly, such as, because of my acromegaly, I try to avoid socializing, or because of my acromegaly, my joints ache. And in this questionnaire, 4 domains are assessed: physical, psychological appearance, personal relations, and then a global score is calculated. And you'll see a lot of the studies that have looked at quality of life use this ACRO-QOL questionnaire, and they also may use some of the more generic health-related quality of life questionnaires. So there have been innumerable studies that have demonstrated an improvement in quality of life following biochemical control of acromegaly, which again we'll define as a normal IGF-1 level, whether that's through surgery or medical treatment or radiation. So I'll share just over the next couple of slides some data from a systematic review and meta-analysis from 2021 that assessed the effect of treatment on symptoms and health-related quality of life in acromegaly. And listed on the left are some of the studies that were included in the meta-analysis. This particular slide is the symptom of hyperhidrosis or excess sweating. And you can see that there was an overall decrease in the symptom score, which corresponds to an improvement in sweating following treatment. And in fact, there was an overall improvement in symptom score for all 6 of the symptoms that are listed here: paresthesias, hyperhidrosis, fatigue, arthralgias, headache, and soft tissue swelling. And that's the order in which sort of the effect was the greatest. So they saw overall in this study the greatest improvement in paresthesias following treatment for acromegaly, and an improvement, but a sort of less improvement for soft tissue swelling. This is another kind of domain they looked at. This is called the Patient Assessed Acromegaly Symptom Questionnaire, or the PASQ. And this was a questionnaire that assessed 5 acromegaly-related symptoms, which you can see listed here. And it's a cumulative score that's calculated. And as you can see at the bottom, overall, there was a decrease in the PASQ score, which corresponds to an improvement in symptoms following treatment. And then finally, here's the ACRO-QOL score, which I had referenced before. This is that acromegaly disease-specific quality of life questionnaire. And for this particular questionnaire, a higher score indicates a better quality of life. And so they noted that out of 22 studies, quality of life by this ACRO-QOL questionnaire improved in 12 of the studies and remained unchanged in 10 of the studies following treatment. If you look at the overall change across all studies at the bottom, you can see that the ACRO-QOL score increased or improved following treatment. This kind of figure comes from a prospective study that was published in 2020. In this study, they examined health-related quality of life in 27 treatment-naive patients before and then during the first 2.5 years of treatment. Most of the patients underwent transsphenoidal surgery, and then many of them were also treated with medication. You can see on the x-axis is time in months. On the y-axis is the mean acro-QOL score. And I think what's really interesting and important for patients to know is the improvement in quality of life appears to be most pronounced in that first 1 year following treatment. And in this study, the most significant increases were in the appearance domain and the physical domain. So although we know that quality of life improves with treatment of acromegaly, it does not return to normal, unfortunately. So this is data from a cross-sectional study from China that included 327 patients, so a really large study. And they studied these patients at an average of 10 years after their treatment. And about half of the patients were biochemically controlled with a normal IGF-1 level. So these are data from the short form 12 questionnaire, which is a generic health-related quality of life questionnaire that assesses multiple physical and psychological dimensions, which you can see listed on the x-axis and then kind of written out there on the right. The scores are on the y-axis. And as you can see, the patients who were biochemically controlled, who are the patients in green, had significantly higher scores, which corresponded to better quality of life than uncontrolled patients in most of the SF-12 dimensions. That's certainly what we'd expect. Patients, however, with either controlled or uncontrolled acromegaly had significantly worse quality of life than the age and sex-adjusted population reference, which is in blue, for really all of the dimensions that were studied with the exception of physical functioning. So although biochemical control is our goal during treatment, this does not necessarily equate to symptom control. And so I wanted to present some data to highlight that. So this was a really interesting double-blind, placebo-controlled crossover study of 20 patients who were treated with long-term, at least 36 months, of long-acting somatostatin analogs, and they were all biochemically controlled. So again, defined as a normal IGF-1 level. And these subjects in this study, even though they were on somatostatin analogs, they were biochemically controlled, they then received the addition of pegvisomant or placebo for 2 consecutive treatment periods of 16 weeks and separated by a washout period of 4 weeks. And the black dots correspond to patients who were treated with pegvisomant first and then followed by placebo. The white dots correspond to patients treated with placebo first, followed by pegvisomant. And quality of life was assessed by the acro-QOL questionnaire before and then after the treatment period. And you can see time is on the x-axis, time in weeks, and then the change in the acro-QOL score is on the y-axis. And they saw that for both the total acro-QOL and the acro-QOL physical domain, that quality of life scores improved following treatment with pegvisomant and then returned to baseline or remained at baseline if the patients had been on placebo first. And then when we're on placebo, we're unchanged. So essentially, and this was the case kind of regardless of the order of treatment. So again, just to sort of highlight this, these are patients on somatostatin analogs with a normal IGF-1 who then got additionally pegvisomant added and noted an improvement in their quality of life. And then this was a study, Eliza Geer, and I believe, Jill, you're on this study. So I just want to highlight this really informative study that was a survey of 47 patient and medical provider pairs about their outcomes. And all of these patients were on long-acting somatostatin analogs with a normal IGF-1 level and thus were considered biochemically controlled. Despite biochemical control, many patients reported symptoms of acromegaly, and notably, there was a significant discordance between patients and medical providers on the frequency and severity of symptoms. So medical providers were less likely than patients to report headache, hyperhidrosis, joint pain, swelling, carpal tunnel syndrome, and snoring, and they were more likely than patients to report fatigue. Additionally, and really importantly, medical providers rated symptoms as severe less often than patients. And there was also a discordance on the frequency and severity of injection site reactions reported by patients and their medical providers. So I just share these these two studies in particular because I think they highlight that patients who are on somatostatin analogs can still have acromegaly symptoms and quality of life impairments, despite what we would consider to be adequate treatment and a normalization of the IGF-1 level. So I want to shift gears a little bit and talk about some of the factors that have been studied that may affect quality of life in acromegaly. So we'll start first with radiation treatment. So many of the studies that have assessed quality of life in acromegaly are cross-sectional. This particular study was actually designed to assess the longitudinal change in quality of life over a 4-year time period in patients who had sustained biochemical control. And they did also look at determinants of quality of life. So this was a study of 82 patients with a mean duration of biochemical control of 11.5 years. And patients, as you can see, had undergone a variety of treatments, including surgery, with or without radiation, and then with or without somatostatin analogs, and as well as combination treatment. And quality of life was assessed by 4 health-related quality of life questionnaires and the ACRO-QOL. So they saw that over 4 years, again, these are patients with sustained biochemical control of their acromegaly, quality of life in 5 of the 26 subscales worsened. That was physical functioning, social functioning, physical fatigue, psychological well-being, and personal relations. They did find that radiation treatment, as they looked at these determinants of quality of life, that radiation treatment negatively influenced 10 quality of life subscales at follow-up. Those included energy, pain, social isolation, physical fatigue, reduction in activity, motivation, depression, anxiety, and physical performance. And many studies, not all, but many have demonstrated a detrimental effect of radiation treatment on quality of life in acromegaly. The effects of various radiation therapy techniques, however, have not been formally evaluated. So advanced radiation therapy techniques such as stereotactic radiosurgery, proton beam therapy may be associated with a decreased risk of impaired cognition and seizures compared with conventional radiotherapy because of lower radiation exposure of the healthy brain, but this really has not been formally evaluated in acromegaly. So moving now to growth hormone deficiency. So this was a cross-sectional study from our group in which we compared quality of life in a total of 45 patients with treated acromegaly, and about half of them had growth hormone deficiency. Those are the black bars. The other half had growth hormone sufficiency, the gray bars, and quality of life was assessed by the SF-36, which is a generic health-related quality of life questionnaire, very similar to the SF-12 questionnaire that assesses 8 physical and psychological domains. We also assessed quality of life using the symptom questionnaire, which evaluates anxiety, depression, anger, and hostility, and somatic symptoms. And we found that quality of life was significantly impaired in the growth hormone deficient subjects in all of the SF-36 domains and on the depression and the somatic domains of the symptom questionnaire. And these findings are notable because about half of patients or more develop growth hormone deficiency following surgery or surgery combined with radiation treatment. And notably, in this particular study, we did not see an association between radiation treatment and quality of life. So the effects of growth hormone deficiency on quality of life, at least in this study, appeared independent of radiation treatment. You might ask then, should we be replacing growth hormone in patients who have growth hormone deficiency? There was a subsequent study that our group conducted in which it was a 6-month randomized placebo-controlled study of growth hormone replacement in patients with acromegaly who developed growth hormone deficiency after surgery or after surgery plus radiation. And we did demonstrate an improvement in quality of life with a growth hormone replacement. However, in general, routine growth hormone replacement in patients with acromegaly who develop growth hormone deficiency is not typically recommended due to some potential adverse events, vascular events, but there are certainly some patients out there, including in our center, that we see who are on treatment with growth hormone and are doing quite well. So our group, I thought this was really interesting, also sought to understand whether there are differential effects of pharmacotherapy on quality of life. So this was a cross-sectional study of patients who were on monotherapy with either a long-acting somatostatin analog or pegvisomant, and all of the patients were biochemically controlled with a normal IGF-1 level. Most patients had undergone surgery, some had undergone radiation. We did include patients with active acromegaly as a comparison group, but the main comparison was really quality of life in patients who were on somatostatin analogs versus quality of life in patients who were on pegvisomant. And we assessed quality of life by 3 questionnaires: the disease-specific ACRO-QOL questionnaire, the SF-36 questionnaire, and then a gastrointestinal quality of life index questionnaire. And this was chosen particularly given the suspicion, and concern that there may be GI side effects or gastrointestinal side effects reported by some patients who are on somatostatin analogs. We found, however, no differences in quality of life in any of the domains between patients who were treated with somatostatin analogs and pegvisomant. And this was despite the fact that patients in the pegvisomant group had more severe disease, which was evidenced by the high number of these patients that had been previously treated with somatostatin analogs that were ineffective. So our conclusion was that the quality of life is comparable in patients treated with somatostatin analogs and pegvisomant monotherapy. As you've heard in prior talks, and may have experienced, many people require multimodal therapy with surgery, radiation treatment, and pharmacologic treatment, or some combination of that. And I think an important question is whether quality of life differs in patients who require medical treatment after surgery or after surgery and radiation from those patients that do not, from the patients that are cured by surgery. So this study assessed quality of life in 3 groups of patients, all of whom had undergone surgery, some of whom were treated with radiation. Group 2 includes everyone on medication, and group 3, which was a subgroup of group 2, includes only patients who were biochemically controlled on medication. And these patients had a mean duration of disease for about 10 to 12 years. They assessed quality of life by the ACRO-QOL, the fatigue severity scale, the SF-36, and they found no difference in quality of life by any domain when comparing groups 1 and 2, which are the patients that were cured by surgery versus those on medications, and when comparing groups 1 and 3. So these are patients cured by surgery versus patients who were biochemically controlled on medication after surgery. The patients actually in that latter group had a better SF-36 physical health composite score, and otherwise no differences. So their conclusion was that quality of life is comparable, if not perhaps slightly better, in the physical domains for patients who do require medical treatment after surgery. We also addressed the same question in our patients. We compared long-term quality of life in patients who were biochemically controlled on medical therapy, which we call the MED group, versus those who were in remission after surgery or after surgery combined with radiation. That's the no-med group. All of these patients had undergone surgery. About 40% had been treated with radiation, and subjects in the no-med group had undergone assessment for growth hormone deficiency, and about 40% of those did have diagnosed growth hormone deficiency. The duration of biochemical control was really long. So for both groups, it was 15 to 20 years of biochemical control, so normal IGF-1 level. And it's important to note that the patients who were in the med group had been on chronic medical therapy for many, many years. About 2/3 were on somatostatin analogs, and 1/3 were on pegvisomant long-term. And we assessed quality of life by 5 questionnaires, as you can see listed here. Overall, the quality of life by the SF-36 remained below normal in both of the groups combined. About 58% of patients scored in the lowest quartile on at least one SF-36 domain, and about 30% of patients scored in the lowest quartile on half or more domains. This graph depicts the percentage of patients scoring in the lowest quartile for each SF-36 domain, broken down by group. So the black bars are patients who are biochemically controlled on pharmacotherapy, on medication. The gray bars are those who are cured with surgery or surgery plus radiation. Overall, the quality of life scores were the worst for the domains of general health, energy, fatigue, and pain, but there were no significant differences between the groups, really in any domain, actually. So, skipping ahead here. Okay, so we also assessed predictors of long-term quality of life and found that growth hormone deficiency, a greater number of pituitary hormone deficiencies, and hypothyroidism were associated with impaired quality of life. And this graph depicts the mean SF36 scores for patients with growth hormone deficiency, which are the solid bars, and growth hormone sufficiency, were the hash bars. And you can see quality of life by the SF36 was significantly worse in the patients with growth hormone deficiency for 4 of the domains. Radiation treatment, adrenal insufficiency, hypogonadism, and the duration of biochemical control were not associated with impairments in long-term quality of life. And then finally, as a secondary analysis, we were interested in assessing the change in quality of life over time in these patients who had decades of sustained biochemical control. I'll just kind of skip ahead to the main meat of the conclusion, which is that there was a deteriorate in the med group, the patients on chronic medical therapy. They actually had an improvement over time in physical, psychological, and appearance domains of the acro-QOL. And for the patients who were not on medication but had been cured by surgery, there was a deterioration in pain domain and physical health composite scores, as well as some other scores, as you can see here. So the current clinical practice guidelines for acromegaly recommend pharmacologic treatment in patients with persistent disease following surgery. And our studies suggest that chronic long-term pharmacologic treatment following surgery is not detrimental to quality of life, even with factors such as perhaps medication side effects or the burden of being on injections. So I'll just close with the last couple minutes, some thoughts on how we can use this to improve patient care. I think one of the most critical elements we'd all agree on is communication. So we discussed some data that demonstrate the discordance between patients' reported symptoms and symptoms reported by providers in patients who have biochemical control. So I think we need to recognize that biochemical control does not necessarily equate to symptom control for all patients. And so a multidisciplinary approach is really important to address some of the physical and psychological symptoms of acromegaly. And certainly educational programs like this, I think, is one way of bridging the gap between patients and providers. So really fortunate that we can have these forums. This is the last slide of data I'll share. This is just this was a study, a survey of 78 people with acromegaly. Maybe some of you attended this. This was from the MGH Virtual Acromegaly Day in 2021. Memorial Sloan Kettering also had a virtual acromegaly day in 2021 around the same time. And so we surveyed at both sites participants about their care goals and their unmet needs, and we reported collectively the results. So nearly 70% of people identified quality of life or mental health as an important care goal. You can see that in the pie graph that's in gray. We also surveyed people on their attitudes towards their disease before and after the educational programs. And it was great to see that following the event, fewer people reported having no hope for improvement. In fact, everyone who completed the survey reported having at least some hope for improvement. Additionally, fewer patients reported having no choice in their treatment, and fewer patients reported feeling alone living with acromegaly. So I think in addition to providing education, I think everyone would agree that forums like this are a great way to foster a sense of community for patients who have acromegaly. So this is the last slide. I just want to summarize this, that the impaired quality of life who are experienced by people with acromegaly may relate to physical symptoms, psychological symptoms, and treatment effects. Quality of life does improve following biochemical control of acromegaly, and that can be through surgery, radiation, or pharmacotherapy, but it does not normalize in most of the cases, at least the research studies that have published on this. And some of the factors that are associated with impaired quality of life include growth hormone deficiency and radiation treatment. Long-term pharmacologic treatment is not detrimental to quality of life and should be considered, in some cases, maybe over radiotherapy, just given the risks of hypopituitarism that are associated with radiation in people who have persistent disease following surgery. So thank you so much for your attention, and happy to take any questions by email.